Joining us now to talk about your health is Dr. Kalpesh Vakharia, Chief of Facial Plastic and Reconstructive Surgery at the University of Maryland Medical Center and Associate Professor of Otorhinolaryngology at the University of Maryland School of Medicine. And we will come back to that term in a minute. But Doctor, thank you for joining us. You were recently involved in a first of its kind procedure. What were the challenges of this case?
Thank you for the opportunity to be here. So this was a first of the kind, working with two other surgeons, a neurosurgeon, Dr. Mohammed Labib, and a rhinologist who is also an otolaryngologist, Dr. Andrea Hebert. And so us three worked together to try to figure out how to take care of this patient that had a tumor of the spine. And this is generally an area that is not accessible easily. So
it was high up in the spine,
yes,
and you couldn't get to it safely from the back.
Right, because so the tumor sat in front, so you have your spinal cord and then you have your vertebral bodies. So if a tumor is sitting behind the spinal cord, then you can access it from the back. But if it's sitting in front of the spinal cord, you have to access it from the front. And so when it gets into this region between the skull and as you transition to the neck, that's right behind your facial skeleton. So this becomes a very challenging area to access.
We have a graphic that is not graphic, but depicts exactly how you guys did this. Mm-hmm. And it made a lot of news, made national news, because as people can see there, one instrument or implement went through a nostril. The other appears to be going through an eye socket. Mm-hmm. How did that work?
Right, so the approach, so the challenge is getting low enough on the spine through the nose was what one of the limitations was. So the thought is if we could come from above or a point higher from the nose, it'll be able to angle us downward, and so we can get a little bit lower on the spine where our patient's tumor was. And so I accessed through incisions through the mouth and on the inner portion of the eyelid and at the corner of the eyelid, so all very well hidden incisions, and removed a portion of the face of the upper jaw as well as areas of the eye socket. So Dr. Labib and Dr. Hebert could use the four-handed technique to pass instruments between the nose and the eye socket to get down to the spine.
And the patient, successful surgery,
mm-hmm,
still has eyesight.
She still has eyesight, yes.
Just amazing stuff. I mean, are the instruments that small? Must be smaller than I can imagine.
Yeah, so they're fairly small, but they also have to be very long. As you can imagine, you have to start here, and you have to end up deep in the center of your head, spine, neck area. And so you need long, small instruments that are very precise, because as Dr. Labib is drilling the bone or the tumor or working on the tumor, millimeters can make a huge difference when you're dealing with the spine.
Patient, a young woman, unfortunately dealing with this and doing well. But I'm curious, when you were explaining all this to the patient, what was the reaction?
The patient really took it in strides, the patient and the family that was there. And so I think she recognized that her tumor and her situation was very unique, and in many situations this was thought to be inoperable or an area that you could not do surgery in, ordinarily would be treated in some other manner. And so she was very understanding to my surprise.
The techniques that you and the team developed for this, does it have potential other applications? I mean, you certainly learned from this. Mm-hmm. Does that information get carried forward? Yeah,
I think it gets carried forward, and I have to credit the people that were from behind me that gave me the tools to be able to do this. And so being at shock trauma, where I take care of a lot of trauma patients, facial fractures, a lot of the techniques that I was employing were a part of that experience and from that experience. Similarly, Dr. Hebert, Dr. Labib, using techniques that they've used before. I think the novelty here is we've done we're applying all these different techniques in a way that in treating a patient that was in a way not able to be treated before this technique combination.
I'm curious about your shock trauma work, obviously part of the University of Maryland Medical Center complex, and you see all sorts of impact injuries from car accidents and so forth. Do you see more of that or less of that in the airbag age?
We see a lot of that. We unfortunately see a lot of gunshot wounds.
To the face.
To the face. We see a lot of hand assaults, hand-to-hand combat, and sequelae related to that. So.
Aside from the trauma and procedures like this, what's the bulk of the procedures that you and your team work on?
So for me, as a facial plastic reconstructive surgeon in the department, I have a pretty broad practice, and so it's one's called a hybrid practice, where it's a combination of aesthetic as well as reconstructive. And so my reconstructive work centers primarily around trauma as well as reconstruction after cancer, whether it's skin cancer or various head and neck cancers. My aesthetic work focuses around what in general the field of facial plastic surgery encompasses, which is making people look younger, fighting the issues of facial aging. And so the standard procedures are like eyelid surgery, facelifts, rhinoplasty.
Overall in your practice, we established the instruments have gotten smaller. Have the techniques changed? I mean, what's been learned in just the time you've been practicing?
Oh, the techniques have changed drastically. So I've been attending at University of Maryland since 2012. And so new procedures just like the one we've described have come. New techniques have come and new technology. I think the introduction of computer modeling and pre-planning has really made surgeries that were in the past thought to be not possible really a reality now.
I made note at the beginning when I managed to get through, I think it's 9 syllables of otorhinolaryngology. You said there's more to it.
Yeah, so it's also called otolaryngology - head and neck surgery, kind of encompassing the broad but specific aspects of the field.
We're heading into summer season. People are outdoors more. The sun is shining. You mentioned having the ability to do reconstruction in facial cancer cases. When does that apply? Is that, we've talked about what's called Mohs surgery, I think. Is that your department or that's something else?
That's in the Department of Dermatology. So majority of Mohs surgeons are dermatologists, and they take care of cancers. They will remove the cancer. A lot of them do their own reconstruction. When the reconstruction gets more complicated, requiring an operating room or operating theater and requiring a multi-stage scenario, that's when they'll often refer to a surgeon like myself.
The term plastic surgery may be misunderstood a little bit. I mean, it sort of has magical connotations that you're able to operate without causing any scarring. Is that possible yet?
So a lot of my field works on trying to minimize scarring, and when you make a scar, making it as well hidden as possible, imperceptible, and making it heal as best as you can. And so I think that's the medicine and the art of plastic surgery.
And that takes us back to the reason for doing this tumor surgery through the eye socket, right? I mean, that's part of it.
Right. So part of it was the position of the eye socket in relation to that area of the spine made the angles and the math and the vectors appropriate. But the approach that I specifically took, rather than making incisions on the face that are more noticeable, I've hidden as many of the scars as I possibly could in areas where no one would ever know.
How do you do that? I'm curious because I read once that any time skin is cut in surgery, you're going to get some kind of scar.
Yeah. So that is correct. So whenever skin is cut, any cuts that are made, you're going to get a scar. But if you imagine if you make a cut at the corner of your eye, where when you smile, you're going to form wrinkles. And so that's a well-hidden scar. So in our patient, that's one of the cuts that I made. If you make the cut on the inner portion of the eyelid, no one's able to see the inner portion of the eyelid, or if you make a cut inside the mouth. And so it was through this different series of cuts that I was able to give Dr. Labib and Dr. Hebert the exposure they needed.
Are there other techniques to minimize scarring? And does the amount of scarring differ depending what type of skin we're going through? Some really thin skin or something tougher, thicker?
Yeah, so there's a lot of variables that factor into how one scars, how good of a scar ends up. Things like what diseases they bring to the table if they, let's say, have diabetes, their age, their period in life, sun exposure before or after, all kind of factor in, and the area that we're operating in. And so there's certain parts of the face that scar way better than one would expect, and other parts that don't scar as well. And so you have to figure out how to minimize the areas that don't scar as well.
I'm interested when you teach, the professor at the University of Maryland School of Medicine. What are your students most interested in this field? Is the hot area doing rhinoplasties and eye lifts and so forth, or?
I think that seems to change. There's a lot of pendulum swinging that goes on as I've been, in a professor role. And so it really depends on the year, depends on the student. And a lot of it depends on like what they're bringing to the table, what the interest they have from, their pre-medical school life.
I wanted to bring up one more point with respect to the groundbreaking surgery that brought you here to talk to us, which would not have been possible but for the people who had donated their bodies to science, because you needed to rehearse some of these techniques.
Yes, and we credit, and it starts very early in medical school. I know after anatomy lab, we had a ceremony, basically appreciating and thanking those individuals that donated their body to science for us to learn. And that still applies, until now. This would not have been possible without the preparation that us three surgeons had done prior to the day of surgery to make sure everything went smoothly.
Dr. Kalpesh Vakharia, University of Maryland School of Medicine and the University of Maryland Medical Center. Sir, thank you for your time.
Thank you for having me.